got 8 chronic conditions on 15 medications, you do need pharmacogenomic testing to know what they're contraindicated to, what's going to metabolize properly. All this information today in Medicare, if you're not the plan, it's very, very difficult to get access to. And even if you're the plan and you have access to it, then you have to actually be in a trustworthy relationship with the primary care physician where they're actually motivated to use what you're surfacing to them. They trust the data, where the data sources where it's coming from. Suggestions that you give them are actually tied to clinical evidence that is auditable, that they can look at the point of care. And that doesn't necessarily mean that they're not going to have a lot of questions. But at least in Medicare, you have an opportunity to engage with a physician. There's another patient visit that may be happening. So accurate data and actual information is one part of it, but it's part of that engagement as well, where you're actually in a clinical conversation with the physician, because the physician in the plan, you are the entity that is paying him or her, and so you do have a way to drive engagement that way as well.
So I'm gonna, I think that's dead right. I'm gonna ask you a bit, I'll ask you a question now. What about Eric von Schreber can come up on stage? Eric's somewhere, I hope, backstage. Eric from Surveyor Health is gonna come up and join us on the couch here. Come sit right here, Eric.
Hi all.
We're going to go, so this is a leading question, but I'm going to ask you what kind of both technology and intellectual property capital you have and human capital you have to make those decisions at the plan level. And there's a question we're going to raise into is, what happens at the plan versus what happens at the clinician level. But what do you have on board in terms of data scientists, medical directors, pharmacists, to start thinking about making those decisions to help your clinicians?
I think for a Medicare plan, we're unusually weighted to a meaningful amount of individuals who are physicians, not from physicians as it relates to engaging with external physicians daily, but around evidence-based guidelines, clinical decision-making. We do think it's difficult to come into a clinical organization without a lot of experience with clinical informatics. We think that's difficult. It doesn't mean that we don't want to balance there, but there's a lot of known knowns that if you haven't manipulated healthcare data for a significant amount of time, if you haven't been steeped in how clinical evidence is practically used at the point of care, it's very difficult to get up to speed in those areas in a short amount of time.
All right, so we're going to dive into an example of this right now. So I have with us, we have on the podium Jenny Nguyen. She's a clinical pharmacist and the program director at Preveon Health. Preveon is a pharmacy organization that is subcontracting to Inland Empire, a big Medicaid plan down in Southern California. And with me is Eric von Schreber, old friend of Health 2.0, who was last on the set to me before we got here, so 2011, 2012, showing a very early version.
So wild.
Early version of Surveyor Health. So you are working as a three-legged stool together. Do you want to just give us a quick intro, Eric, into that?
Sure. So the way we got into this, when we started out as a company, we were AI before it was fashionable, and we were applying AI in a different way. We were using it as IA, intelligence augmentation, to make clinical pharmacists and other clinicians better, faster, stronger, sort of like $6 Million Man-esque. More recently to that, as you noticed, for aggressive, Chris Ross yesterday in his talk, the CIO from Mayo, he was exposing how much complexity there is in healthcare that you don't have in other industries where displays and record management systems are sufficient. And we've acknowledged that right from the start. So we've tried to make our clinicians better, faster, stronger to deal with this complexity. But more recently, we've taken our core AI that we've proven at DARPA, the Defense Advanced Research Projects Agency, and we've now applied it to automate intelligence in the cloud. For example, in population health, in member stratification using things like Bayesian network inference and combinatorial optimization. And more recently, in fact, in the last 2 years, with Inland Empire, with Preveon, we brought the two together. So you basically have your autonomous intelligence identifying impending train wrecks, patients that are not as bad, but you could move the needle on and get some improvement within your reporting and measurement period. So we've done that, and we've brought those two sides together, and this is the first example of this collaboration, where Inland Empire, one of the top 10 managed Medicaid players in the US, is working under RFP with Preveon Health, who is a disease management company, often focused in diabetes, but now doing comprehensive medication management, CMM, and we're providing the technology platform. So actually, let's take a look at that. So if you look at this as a data flow, in the upper left-hand corner, you have Inland Empire. They're providing data not just from themselves, but from their PBM, from their lab companies, and we pull that data into our platform, reconcile it, clean it, cleanse it, integrate it, etc. Make it a usable resource. We then apply our multidimensional AI to it in order to stratify that membership and put the patients most in need of review, or patients that we can move the needle on, into an encounter pool, which you see in the right side. That is then used by Preveon clinical pharmacists. You're going to see Jenny provide this and demo it for you, to look at a real case, to do a workup, to do a consult, interact with the patient, and based on that analysis, either pose recommendations or under a collaborative practice agreement, actually make changes, and then forward generated documentation to the patient as well as the provider and to the payer as well. And then it's rinse and repeat. The system repeats itself with analytics, etc. And so that's the demo you're going to see. We're going to already look at that top right-hand corner as it descends down into stratification and decision support, and see that demonstration.
Right, so Jenny, if you're ready, please take it away and show us the actual tool.
Okay, well, hello and good morning, everyone. My name is Jenny. I'm a clinical pharmacist. I'm also the program director at Preveon Health. And so our demo patient today will be Maria Alvarez. Due to time constraints, this encounter has already been started for this patient. And so from the encounters pool, I will just click on continue encounter, which would then take me to the patient's main page. And so at Preveon Health, usually what happens is our medical assistants or MAs, they call out to the patient, they conduct the initial health survey, and then they transfer the patient over to the pharmacist. An important task that they also complete is going through the patient's medication history, which is here, found in the medication regimen section. We also call this our MedRec section. And here our MAs input in relevant information for the pharmacist, such as whether or not the patient is still taking the medication, and if they are, how they are taking the medication. This section is also a very useful tool for the pharmacist to help assess compliance and also detect any medication issues. So for example, we see here that the patient indicates that she is taking both the lisinopril and the lisinopril hydrochlorothiazide combination daily. And so looking into the fill history, we see that for the monotherapy, she has been taking this consistently for quite a while. However, for the combination medication, it looks like she just recently picked this medication up. And so what could have happened is the provider switched her over to the combination to better manage her hypertension, but just forgot to discontinue the monotherapy. And so the pharmacist can further investigate down below here in the MedRisk Map section. This section is also a very helpful clinical tool for the pharmacist because it helps them view any relevant labs. It also helps them see at a glance any medication issues such as contraindications, precautions, side effects, DDIs, and duplicate therapy. And so just to highlight a few of these sections from top to bottom, in the clinical essentials, we see the patient's labs, and we see at a glance here, the patient may have some renal issues and also hyperkalemia. So this hyperkalemia could be due to that lisinopril duplicate therapy, but it could also be due to other medications. And so what the pharmacist can do to further investigate is put in the ADR in the search section here. And then in the side effects, we will see that the culprit of the hyperkalemia is indeed that lisinopril and the lisinopril combination. And down below, the duplicate therapy is also a very neat tool for the pharmacist because it lets them see visually at a glance all the duplicate therapies that exist on the patient's profile. And so here we see in the ACE inhibitors that duplicate therapy that exists between the lisinopril and the lisinopril combination. And so based on all the information gathered, the pharmacist can then recommend to the pharmacist to discontinue that monotherapy. And they can do that by just unchecking the after map it box here, which would then, the discontinue action plan would be recorded down below in the finalize encounter section. And so any action that you do, whether it's discontinue, adding, or replacing a medication, will be recorded below in the finalize encounter section here, so that it could then be added to the provider or the patient's report. And so in the finalize encounter section here, we see our action to discontinue the lisinopril. There's also a note field here to indicate the reasoning behind our recommendation, and here we can utilize our smart phrases to help save time. And when the pharmacist is finished with all the recommendations, we can generate the report for the patient or the provider above here. Now, these reports are highly customizable. You can indicate which recommendation, concern, or lab that you want to put on the report. So here's a sample provider report. You see under the action plan here, the recommendation to discontinue the lisinopril, the reasoning. Down below here is the concern of the labs that we selected to be placed on the report. And finally, we see the patient's most up-to-date medication list. And that concludes my demo.
And Jenny, how does that report, so now you've done all that in the background from the disease management aspect and the pharmacist action aspect, how does that get communicated to the physician?
It gets faxed over. If there is a drug alert, our MAs also call the clinic to make sure that they received it, and also highlighting any notes from the pharmacist.
Okay, so prompt communication of it from you out to the independent physicians. So Eric, you've got some early stage feedback as to how this is working, so show that chart.
Sure. So this is phase.
Already.
Sure. This is phase 1 result, and by the way, this is an N of thousands, so we're not talking about a tiny study. We saw initially a huge drop in opioid prescriptions and duplications, a drop in DURs such as interactions and dupes. One of the key things is this is not by focusing on can we find duplicative opioids. This is a holistic, system-wide evaluation and set of recommendations. It's holistic. Now, in phase 2, what we're under currently, we have 2 parts. Part 1 is going from this work and extending it out to full examination of total cost of care. And preliminary results are showing a positive trend to greatly reduce utilization across admits, readmits, PCP visits, specialist visits, ER, etc. Also in phase 2, we found that with Preveon's disease management program for diabetes, we had some patients in common for CMM, comprehensive medication management, and the combined actions were even better. So we're now doing a fully randomized control study of a combined program coupling comprehensive medication management with comprehensive disease management. And stay tuned.
All right, fantastic. Jenny, why don't you come join us, please, on the couch? So I have this demo here, and I thought it'd be interesting because, to some extent, back in the day, when we talked about the 80s and the 90s and the early years, health plans did health plan stuff, doctors and hospitals did doctors and hospital stuff. That's obviously changing. This is an example of a health plan taking data, and Vivek, you mentioned having all this different data that they have and directing it out to make some significant changes, and by all accounts, looking like there are some big differences and some improvements in the care being delivered out to their population. Having said that, those were something showed Tony about being around a while. Those who have seen the disease management and the attempts to do this by health plans haven't always been that successful. So I want to sort of get into a little bit of philosophical discussion here about what is the role that you consider your plans to be doing. Vivek, I'll leave you for a second because you've talked a fair amount about how we're doing that. But perhaps Oscar or Bind, how far down the path of getting involved in this level of clinical, deeply into the clinical activity of the clinicians and of the patients, do you think you're going to go?
I can start.
Yeah, go ahead, please.
Oscar's strategy with respect to care delivery and sort of our involvement in the clinical component is really just about partnership and collaboration with our provider partners. So, for example, with several of our health systems, we share risk, right? So we have very aligned incentives. We all want the same, bettering of outcomes. And so we really believe it is a collaboration. And so, for example, we offer a virtual care, telemedicine service to our members. We are hoping to expand that offering and provide even more convenient access to basic care services for our members, mainly because it's a consumer need. And we work really closely with our partners to figure out how to engage them in that in an effective way and how to make sure that we're aligned in the way that we're delivering that care. We also have, many of us have talked about data science functions, we also have those, and we look regularly at the activity happening in our networks to make sure that if we identify any opportunities, whether it is for clinical quality improvements, or even like administrative efficiency gains, that we can then go work with our partners to figure out how to facilitate that. We also, the telemedicine service we offer is delivered by a captive physician corporation. We work a lot on the tooling for them so that they have the same kind of tools you were describing, really know what are actionable things they can work on with each individual member. On the consumer side, we focus a lot, I've said several times, on engaging the consumer and empowering them to make the better decisions. So for example, whether it is switch from this drug to a clinical equivalent that is lower cost, or helping them make sure they're adhering to their medication regimen, or even things like avoiding unnecessary ER admission. All things like that we are very engaged with, and again, work closely with our partners to make sure we have aligned care plans and aligned interventions that we are driving.
Is there a place where your clinical function stops and your partners start, or should an outside observer not be able to tell the difference if it's working well?
Yeah, I think the ideal is that it feels as though it's one cohesive experience for a consumer. Behind the scenes, we do have some tooling that we put in front of the provider. So for example, we have a provider-facing application, we have a clinical dashboard. What I believe is really the most important thing is that we share the right data with the right people so that we collectively can manage our patients in the best way. So for example, you mentioned earlier that the payer has some data available to them, given that they're in the middle of all the payment flows and the claims processing, that not all providers have access to. And so when we partner with the health system, we want to make sure they have the full picture of the patient just like we do so that we can work together to most effectively manage the patient. But we are not super involved as much as you are yet in trying to tell them what exactly they should do when they're sitting in front of the patient directly. We are more involved behind the scenes at sort of a macro level of looking for patterns that we can work on with the partnership more broadly.
Tony, what's your sense of where Bine's going to end up in this equation?
Yeah, so I'm going to come off script.
Please do.
So you mentioned our age, so I've been in this industry my entire career. Disease management is not a new concept. Care management is not a new concept. High cost patient review is not a new concept. But if you ever look at the engagement rates and everyone talks about the success they have, but yet we have an ever-growing health insurance, health cost system. So I've always wondered, all the success we're having in disease management, yet we're at $3 trillion right now. Something's really broken here. So we're big believers. It's in our name, actually. We don't believe in health plans. So we don't call ourselves a health plan. We call ourselves a health insurance company because we should just do the insurance really well. And if we do the insurance really well and push the rest of it back to where it belongs, and we really think that whole idea of how care is constructed is really part of the clinical world, the only thing that we think about it differently is we're still using old notions of a system. And remember, we have a system because of Part A, Part B, Part D. Disease does not recognize Part A, Part B, Part D, right? And so the only organizing thing should be conditions to treatment path. And then if you really think about what AI is going to do, it's going to fundamentally change and break down this idea of hospitals, doctors, and drugs. And that might be a 20-year arc, but we think our job is to create an open system where we're pushing payment and incentives to improving condition and treatment path and exposing condition and treatment path to consumers as fast and as quick as possible.
So, Jenny, real quick, when you've been working for Preveon, but working with the clinicians for the Empire for those patients, when you send out these recommendations, when you communicate with them, what's the response you're getting? Are they thinking it's something new and different, or are they more thinking, well, this is the same damn stuff we hear from the health plans that we've been trying to ignore for the last 20 years? Do you think they're valuing you as a partner here?
I think so. So I think we've developed our relationship pretty well among the providers in the Inland Empire over the past 7 years. We do have currently over 600 collaborative agreements with providers in the Inland Empire. And so because I think they were very familiar with our diabetes program, now with the MyMeds program, they are more receptive to our recommendations. And we are different in that a lot of with a lot of NTM programs, what occurs is the pharmacists identify the issue, and then they send the recommendation to the provider, and that's it. But what we do differently is we actually follow up with the provider and the patient to make sure that the recommendation has been completed. We do the status of it, and we also do a step further in that after the recommendation has been performed, we follow up to make sure that, so for instance, if the recommendation is to add a medication, we follow up with the patient to see if they actually picked it up from the pharmacy.
Okay, so there's a lot of
So it's kind of closing the loop completely.
Eric, real quick, so you're a technology platform, I see you don't care at the end who buys it as soon as you get paid.
Actually, we do care. We're in it to improve health.
Okay, so you're careful. But where do you think the end user of a technology like a Surveyor Health ends up being? Does it end up being within a medical group, or is it now coming from the third party, like an insurer who has the data working with their in-house?
Based on our experience over the years, so we've worked with all the largest integrated systems and learned a lot from them. And what we've found is that care is a team sport. Where there's an interest in reducing costs, you want to have people operating at the highest part of their license. So actually getting pharmacists to have prescriptive privileges and act as providers, which of course within certain contexts, they are acknowledged that way here in California. Taking an activity that normally would be or traditionally done by one clinician and figuring out how to parcel it apart and coordinate them to achieve not just the end-to-end goal, but to reduce costs, because now you're not using your most expensive people to do everything.
So you dodged my question well. So it could be anybody, right? Okay,
Yes.
I'm gonna end with exactly one question. So I'm gonna give some of the hard time who's not here, who's Todd Park, one of your, as not yet, but soon to be competitors of Devoted when they come out. And I chatted with him when Devoted was just getting funded, and he basically went through the whole spiel about we're going to build a new stack for the consumer member experience. We're going to build the medical groups interactions, and then we're going to build the at-home services. Somewhat similar to what you were talking about. And I said, didn't you just design Kaiser Permanente? Are we doing something new? Are we trying to get back there again? Do you think that's kind of where we're going to end up with, like a full stack operation that all belongs to Clover? Or do you think we can work a Clover type of a dedicated, effective clinical plan in the US health system that Tony just reminded us hasn't done so great so far?
Yeah, I mean, I'm a little bit controversial, but I kind of view Kaiser as the best of the worst to some extent. It's an amalgamation of just huge amount of fixed assets, and it's very difficult. And if we think about let's take a recent innovation around the iPhone, right? It allowed an application to be layered upon GPS data, and that proliferated all kinds of services, some good, some bad. A Kaiser doesn't really allow for that at the end of the day. And that in many ways constricts what consumers have access to. So when we think about Clover, we don't, if we have to buy a hospital or if we have to buy a practice, that is a failure mode for us from our perspective. We think there's such a huge amount of opportunity in enabling improved clinical decision-making around chronic condition management. That is the biggest lever right now in terms of health outcomes improvement in the elderly population. I mean, in the commercial population, there's huge cost opaqueness that exists, and I think we're seeing the ability to bring transparency there to create a lot of business value.
All right, fantastic. Well, with that, we're out of time. I want to thank Jenny Nguyen, Eric von Schreber from Preveon and Surveyor Health. I want to thank Tony Miller from Bind, Sarah Weinberg from Oscar, Eric Collier from Clover, and please join me in thanking them all. Move on to our next section. All right, well, everyone shuffles off. Let me tell you what's coming up next. So this is going to be a lot of fun. We're now going to have three